Good afternoon and welcome to the National Hispanic Council on Aging's virtual town hall about the ethics of the COVID-19 vaccine allocation and priorities. My name is Christina Pacheco and I am NHCOA's Director of Resource Development and Policy. It is my pleasure to moderate today's town hall. Due to the ongoing COVID-19 pandemic, NHCOA continues developing innovative ways to engage, inform, and listen to the communities that we serve. For 52 years, NHCOA has worked to improve the lives of Hispanic older adults, their families, and caregivers. Even during a pandemic, we continue to work towards our mission. The U.S. Food and Drug Administration has approved 3 COVID-19 vaccines for emergency use: Pfizer, Moderna, and now Johnson & Johnson. These COVID-19 vaccines provide hope for this enduring pandemic. It is no secret that COVID-19 has devastated communities of color, further exacerbating stark health inequities. To address these inequities, promises were made by many, including the newly elected President Biden, that communities of color would not be left behind in the vaccine rollout. Yet communities of color have not necessarily realized this prioritization. Guidelines and frameworks have been established for vaccine distribution, but there are many reports of line jumping. In an effort to keep our communities informed and to share timely, scientifically backed information, NHCOA's third COVID-19 webinar for 2021 is aimed at answering questions and addressing the concerns of communities with regards to vaccine allocation and its priorities. NHCOA continues its dedication to disseminate timely and accurate information while also creating culturally and linguistically sensitive spaces in which Hispanic older adults, their families, and caregivers can come together to discuss issues impacting their lives. NHCOA also strives to connect Latino older adults with local leaders, advocates, service providers, and policymakers to work towards solutions that address their community's specific needs. This town hall is one of those spaces. Today, it is my pleasure to welcome a panel of experts that will highlight current efforts taking place to immunize vulnerable populations. We will take a look at what fair distribution of COVID-19 vaccines looks like. We will hear from the perspective of community health clinics and their experience with the allocation, as well as some other topics. Before we get started, let's pause to thank our sponsors, as this town hall would not be possible without their generous support. Thank you, Lilly, AbbVie, BioNTech, Pharma, the CDC Foundation, United Healthcare, and Pfizer Foundation. To begin the virtual event, we will have opening remarks from some very prestigious people. It is my pleasure to introduce the President and CEO of the National Hispanic Council on Aging, Dr. Yanira Cruz. She is one of the nation's foremost advocates and spokespersons for diverse older adults and is nationally recognized for her commitment and leadership on behalf of diverse older adults. Welcome, Dr. Cruz.
Thank you, Christina, and thanks everyone for joining us, and welcome to everyone. So today we will address the ethics of allocation and priorities in getting the COVID-19 vaccine. One of the key mechanisms public health is using to control the pandemic is the implementation of the recently developed vaccine. And that is wonderful news and an important development in our efforts to end the pandemic. As we roll out the COVID-19 vaccine, we must ask ourselves if we have an equitable response to the pandemic in place. We know that many communities are experiencing challenges accessing the vaccines. It's clear that supply is a problem. A bigger problem is that some older adults in the communities hardest hit by COVID-19 are not able to access the vaccine due to other barriers. For example, to register for a COVID-19 vaccine in Washington, D.C., Maryland, and other states, a person needs to visit their online portal when registration becomes available. Most of our older adults do not have access to a computer, laptop, or smartphone, and those that do are not technologically savvy. Others cannot complete the registration since it's available only in English, which is a huge barrier for those who only speak, read, and write in Spanish. Many online portals have been reported to be difficult to navigate due to the heavy traffic of people trying to get an appointment via this platform. To illustrate this challenge, I'd like to share with you the story of Victoria, who is 72 years old and a resident of the District of Columbia. Victoria did not know how to get enrolled to be vaccinated, since she lives by herself and is trying to stay as safe and as healthy as possible at home. The information didn't get to her, especially online, since she does not have a computer or the knowledge to go through the DC online portal. Then there's also Elia, a 92-year-old who lives in our housing facility in Washington, D.C. Elia was eager to get her vaccine after getting a call from her medical doctor. But the lack of transportation was keeping Elia from getting her vaccine. Now, both Victoria and Elia have now been vaccinated. That's the good news. A group of staff and volunteers at NHCOA helped the older adults enroll for the vaccine and provided transportation to the vaccine location. And so stories like Victoria's and Elia's are unfortunately far too common as older adults across the country struggle to get vaccinated. As we predicted in December, the vaccine distribution process is filled with barriers to obtaining the vaccine, from technology and transportation to logistics and language. So we have some recommendations. First, we urge local governments to work with community leaders to execute a plan to get the people from their community, particularly those at risk, older adults, and persons with disabilities, to have access to the vaccine. Second, establish helplines where people can call to get information, get help with enrollment for the vaccine, and get transportation to the vaccine location for both shots. Third, deliver bilingual automatic voice messages in smartphones and or landline phones on how to get the vaccine by providing a number to call if people cannot access the internet to get an appointment for the vaccine. Fourth, allocate more funding for outreach and education to engage, inform, and activate vulnerable communities to get vaccinated. And lastly, while most states have COVID-19 trackers on public websites, few are reporting disaggregated data showing which populations have received the vaccine. Making transparent the data about who is getting the vaccine allows for greater accountability to that goal. So, following these recommendations creates a foundation for a more equitable response to a pandemic that has attacked the country and its older adults in the most inequitable of ways. Though we recognize that these recommendations do not solve the problem of vaccine scarcity, but they do help ensure people who have been most impacted, like Victoria and Elia, have access to a vaccine that may save their lives. I thank you for joining us today, and now I turn it over to our wonderful facilitator, Christina Pacheco.
Thank you, Dr. Cruz. Our next speaker is Migdalia Vasquez, Director of Provider Engagement and Community Relations for United Healthcare Community Plan of New York. Ms. Vasquez joined United Healthcare in April of 2010. She has over 10 years of experience in managed care on both the provider and member side. Ms. Vasquez has held leadership positions in sales and marketing, outreach, provider relations, and operations. Welcome, Ms. Vasquez.
Good afternoon, everyone. Thank you, Christina, for inviting me. Can you all hear me okay?
Yeah, we can hear you.
Wonderful. Such an honor to join your group today. Just on a personal note, I am really very passionate about working in our communities and ensuring that our populations get this vaccine. It's so important to us to ensure that their safety, and so I'm working, across a number of areas to ensure that happens from United Healthcare's perspective. Just a little bit about me. I am Migdalia Vasquez, and I am the Director of Provider Engagement and Community Relations at United Healthcare. My role is really to help support and engage our provider community to make sure that they have all the tools and systems necessary to take care of our populations and our members. And so really just making sure that, whether it's claims issues or that they don't understand, quality metrics, all these things that go into play to make sure that our members are well taken care of. So that's really my area of focus one. The other area is actually I've been sitting on the New York State Task Force, Vaccine Equity Task Force, and really working with that group to, again, facilitate support for our communities and to ensure, again, that our communities of color are getting the attention they need as it relates to the vaccine. United Healthcare specifically cares for the Medicaid population. We cover about 6.8 million people within the markets that we serve across the country. Medicaid is a healthcare coverage for people with low incomes and covers 1 in 5 Americans, including a significant portion of underserved populations who have been disproportionately impacted by the COVID pandemic. To bring the COVID pandemic under control, I think we will need to be a widespread acceptance and adoption of the COVID vaccine. Currently, however, there remains widespread hesitancy towards the vaccine, especially for high-risk racial, ethnic, and geographic communities. United Healthcare is committed to equity in the COVID vaccination campaign. We have placed a special focus on efforts to help vulnerable populations understand the benefits of the vaccination and how to access the vaccine. Building trust, confidence, and mutual respect are at the foundation of this approach, and recognizing vulnerable populations may be hesitant to get the vaccine. I'll speak a little bit more of that towards the end with a personal story. To reduce vaccine hesitancy and increase community adoption of the COVID vaccine among populations who have hesitancy, it is imperative to ensure that potential hesitant populations are receiving messaging. As Dr. Cruz said, messaging is very, very important in this effort. We understand that the importance of engaging in communities with individuals in an equitable and inclusive way. Collaborating with trusted messengers to tailor and share culturally relevant messages and materials with diverse communities is necessary to build confidence and to instill trust in the vaccine. United Healthcare has a long-standing relationship with the National Hispanic Council on Aging through the United Healthcare National Advisory Board, of which Dr. Cruz sits on. Recognizing the impact of the COVID pandemic has had on traditionally underserved populations, including Hispanic populations, as well as the importance of providing information from trusted resources. We are partnering with the National Hispanic Council on Aging on targeted media campaigns, community resources, and webinars around COVID-19 vaccine. It is through this partnership that we hope to build confidence and instill trust in the vaccine within the Hispanic community. We are very grateful for the partnership, and it is other partners as we reach into the Hispanic community that are trusted and impactful. While we communicate with members often, the National Hispanic Council has a deeper understanding of the Hispanic communities, including their concerns on the vaccine. And we have the ability to reach directly into the community in a unique way. To date, the COVID vaccination campaign has presented a number of challenges. While improving local provider access to vaccines has been limited, this is especially concerning as Kaiser Foundation recently surveyed people where they prefer to be vaccinated, excuse me, for individuals, excuse me, who have not been vaccinated. 75% say they would be likely to get the vaccine at their doctor's office, with 38% saying their doctor's office was where they most prefer to get the vaccine. As we know, the doctor's office today is not a place where you can get the vaccine. You'd have to go to a federally qualified, a site that has been given the vaccine by the federal government. And so that in itself presents a huge barrier for our communities. Says here, surveyed individuals report not feeling comfortable at large federally run vaccination sites and would prefer to be vaccinated by their doctor. They have an established relationship with the provider. So I think that really has to be at the heart of where our communities go to when we start to roll this out a little in a better, more organized way. Ensuring vaccines get to the communities that most need them continues to be an issue. A real-life example highlights this can be found in California when comparing affluent Beverly Hills communities to underserved communities of Boyle Hill Heights. Inequities are apparent. It's not just in California; it's everywhere. We've seen it in New York, where folks in Long Island have traveled to Brooklyn because they have the ability to do that, and residents in Brooklyn and underserved communities don't get access to the vaccine. So we're seeing it as well. I think I want to, one of the things I want to share is, as it relates to hesitancy. So I have an aging parent. My mom is, in her 70s, late 70s, and she was adamant. She did not want to take the vaccine. She says, no, yo no me voy a poner la vacuna. I've heard so many things about the vacuna and the vacuna. I am not going to do it. And so, this is going on for weeks and weeks and weeks, and I'm concerned, right? I want to make sure that she's safe. And so one day she says to me, ¿Tú te vas a poner la vacuna? And I said, I'm going to get the vaccine. When I have the opportunity to do that, I'm going to get the vaccine. Bueno, si tú te la pones, yo me la pongo. If I get the vaccine, then she'll consider getting the vaccine. So back and forth, and so I actually just this past Sunday, because that's one aspect, right? It's the hesitancy, but the other is actually getting the vaccine. I was up at probably about 5 in the morning and thinking, and let me get on the website here. So it so happens that I plug in. Oh, there's a location, there's an appointment. I sign up, and I get an appointment for yesterday afternoon. So I go back in to try to schedule her, but by the time I left and came back, the appointments were gone. But nonetheless, I said, okay, let me just go ahead and let me go through this process. So I speak to her yesterday, and said, Mom, I'm going to go get the vaccine. She says, really? I said, yeah, I'm going to go get it. Well, I went through the line and everything. I was surprised at how well the process went. From the time I went in there to the time I walked out, it was probably about 45 minutes, and very well organized. I came home. How do you feel? I feel great. Are you sick? Should we go to the doctor? I said, no, I feel fine. This morning at about 7 o'clock, she calls me. Mija, ¿cómo te sientes? I feel great. ¿No te sientes nada? You don't feel anything? No, I feel great. I have no issues, no fever, nothing? No, nothing. She goes, okay, I'm going to take the vaccine now. So, I share the story, one is because it's not just my mom. I hear this from other people who are having similar challenges with either their parents or, they're not informed, right? There's not that connection for them. And so, I will be, in fact, working today to try to schedule her to get in there as soon as I can. You know, it would be easier if I could bring her to her doctor, but I can't. So we'll work through the channels to make sure that she gets her vaccine and is taken care of. But, you know, I think it's just one area where there needs to be additional work. Just this morning, I was watching local news here in New York, and if you look at the New York channels, the you know, Channel 7 or whatever news station you want to look at, there's a ticker that says now how many cases of COVID, how many people have been vaccinated, how many people have died, and so on and so forth. If you turn on the Spanish channel, Telemundo, Univision, you don't get that information. Maybe they'll gloss over it, maybe they'll talk about it a little bit, but you don't see that as a ticker on the screen. The messaging is very different. And so I say that there has to be a more coordinated, targeted approach to ensuring that our communities are receiving that information. Because I got to tell you, every day that I see that ticker on the English news that says, you know, 11% were vaccinated, or however many people, you know, across the country, you know, that's hopeful. It's not where we want to be, but it's hopeful, right? So, you know, I will continue to help support that. The other thing is, and I'll leave you with this, is that the other thing I'm seeing is in New York, they've set up overnight 24-hour places where you can go. Yankee Stadium is one of them. I had a woman who was in her 60s who they managed to get her an appointment at 2 o'clock in the morning. She's not going to leave her home at 2 o'clock in the morning to go get a vaccine. It's just not, it's not realistic, and it's not safe. So, you know, things like planning for, you know, like they have in the supermarket, if you're, you know, over the age of 60 or 65, where you can come at 7 in the morning, and they have staggered hours for the folks. Maybe that's something that we can do and advocate for as our communities, to ensure that the communities are getting the vaccines in a timely manner and a time frame that's amenable to them. So, you know, I sort of digressed a little bit on, you know, my talking points here. Again, you know, United Healthcare encourages everyone to get the vaccine as soon as it's available. We're helping members stay informed on COVID vaccines through digital tools. We are encouraging people to stay informed and to discuss the vaccination with the healthcare provider. Talk to the doctors so that, and, you know, collectively with the doctors, so that we're all saying this, sending or providing the same message to our populations. With that, I'll turn it back over to you. Thank you so much for inviting me to your conversation today.
Thank you, Ms. Vasquez. Before ending our welcoming session, let us welcome Pamela Arthur, Vice President of Infectious Disease and Diagnostic Policy at Bio, one of today's sponsors. In this role, she is responsible for working with member companies in vaccines, molecular diagnostics, and biodefense on policy, legislative, and regulatory issues. Ms. Arthur joined Bio in July 2009 as the Director of Healthcare Regulatory Affairs. Welcome, Ms. Arthur.
Thanks so much, Christina, and great to be in this particular panel. Wonderful things were already said, and I will just add a little cap to those. So first, obviously, thanks to Dr. Yanira Cruz from NHCOA. We're so glad to be working with this organization to do educational and access discussions around the Latin American population in the U.S. This is an extremely important topic. As Christina said, Bio, we're a trade association based here in DC. We work with the companies working on different biotechnology areas. I personally have the personal pleasure of working with the companies making vaccines and therapeutics for COVID-19. And will say, I think that we're also pleased and proud of the way industry approached a scientific approach to making these vaccines, one that I hope we can all say embodies trust in the development process, done on a very compressed time frame. I understand that's one of the issues people spend a lot of time worrying about, but making sure that we're all communicating the commitment to the the right evidence so people can see themselves in the data. I think all of the companies have been more transparent, and I hope this continues on their level of engagement of all the different races and ethnicities, underlying conditions, different types of people within the trials, and doing the trials so big, having 30,000 people in the US, so that we could all look at the data and see significant numbers and happily not any significant differences in the way these vaccines actually help to protect people and their safety as well as their efficacy. Both of those have to be managed. So very happy that we have now really good vaccines to use and good therapeutics to use as well. And very excited to see conversations like this take place where people are actually trying to make really good, engaged, and informed decisions. And they're looking to organizations like NHCOA to help them think through the process. And I think that's one of the things we actually are strongly supporting at Bio, is partnering with organizations that have strong, trusted relationships with communities of color, where there's still questions to be answered. I know we're all talking about hesitancy, but I think that actually what we're seeing here is actually some people who've moved from hesitancy to actually eagerness to get vaccinated, and we need to solve the problems for them. And Dr. Cruz, I think you hit on some really important ways we need to do that. There are a lot of people standing in line with their hand up who just don't know where to go to get the vaccine that they want. And they may have felt differently in October of last year, but they're ready now. And we need to take care of those people today. And then, of course, there's people who are still hesitant. And here I mean this in a much more positive way, not the classic vaccine hesitancy you see that's not always based in scientific issues. Here, I think people just have legitimate questions about how this was done. They want to understand it. They want to talk to a trusted healthcare professional. They want to talk to a trusted family member. I think that Ms. Dahlia's example is a perfect one. I'm going through that with my family. I'm sure we all are. And so I think it's extremely important for us to provide people with trusted messengers who are well informed on the vaccines, what they do and don't do, what we do and don't know, and can tell people quite honestly what they need to make a good informed decision for themselves and their family. And so we've created a resource that we'd love people to use as well, if you'd like. It's called covidvaccinefacts.org. It is it's a web-based site. So I think, Dr. Cruz, to your point, that need for a classic helpline, I think we still need that. And I've heard that from my interactions with African American organizations as well as Latin American organizations. We need to use every conceivable communications tool we can to reach as many people as possible through the digital divide. But for those who are web savvy, we have a site called, again, covidvaccinefacts.org. Really easy to use. It's in English and in Spanish. And it's really just answers to questions. So someone can type in, why were these vaccines made so fast, and get a very nice sort of high school level written explanation of how the vaccines were developed. There's also some videos, there's some animation. So all different kinds of communication tools are used to help people get answers to their questions, and then link them to their state sites so they can go and decide to sign up if they want to get vaccinated. I think we need to be working on many more tools like that as a collective stakeholder community, and thinking very much exactly the way the last two speakers said about how people receive information and how people seek healthcare, and facilitating that process both via multiple tools of teaching and multiple ways of getting people in front of an appropriate healthcare provider, pharmacist, nurse, doctor, faith-based organization, community-based organization. We should be using every conceivable place we can to get people vaccinated as quickly as we can. And so we at Bio stand ready to continue to work with all of you to get people through the educational process and into the proper access that they need for the vaccine.
Thank you so much, Ms. Arthur. We are officially 1 year into the COVID-19 pandemic, and hundreds of thousands of lives have been lost in the United States. Worldwide, we have lost more than 2.6 million lives. The novel coronavirus is the greatest threat to our time in the realm of health and our global economy. It spares no one. To date, the U.S. Food and Drug Administration has approved 3 COVID-19 vaccines for emergency use. These vaccines are important tools to help stop the spread of the virus. Let's welcome our first speaker, Marvin Figueroa, Director of the Office of Intergovernmental and External Affairs at the U.S. Department of Health and Human Services. In this capacity, he is the Secretary of Health and Human Services Principal Advisor on strengthening intergovernmental relationships with state, local, territorial, and tribal governments, as well as private sector, nonprofit, faith-based, and other external partners to advance the administration's health and human services priorities. In addition to leading the intergovernmental and external affairs staff in Washington, D.C., Director Figueroa oversees 10 regional offices representing the Secretary and the administration at both the state and local levels. Today, Director Figueroa will provide a brief overview of the administration's plans with regards to the U.S. vaccination response. Welcome, Director Figueroa.
Thank you, Christina. Thank you for the invitation. It's great to be part of this important gathering, and I'm pleased to have the opportunity to engage the National Hispanic Council on Aging. As you mentioned, a little over a year, we were hit with the COVID-19 pandemic, and that has taken over 500,000 lives and counting. As the former Deputy Secretary of Health for the Commonwealth of Virginia, and now as the Director of Intergovernmental and External Affairs at HHS, but also a Honduran immigrant that was raised in the Bronx, I've seen firsthand how the pandemic has disproportionately affected our families and our communities. We know that Latinos are 18% of the U.S. population, yet they represent 21% of COVID-19 infections and 38% of age-adjusted deaths. Before I turn it over to Dr. Lauren Smith from the CDC Foundation, as you mentioned, I want to highlight a few ongoing administration initiatives to increase vaccination rates, but also provide additional relief to the American public. Equity is at the heart of our vaccination program. As part of the President's national strategy, the administration announced last week an effort to invest $250 million to encourage COVID-19 safety and vaccination among underserved populations. HHS will offer the funding as health literacy grants to localities who will partner with community-based organizations to reach racial and ethnic minority and rural and other vulnerable populations. This is in addition to the Centers for Disease Control and Prevention funding for organizations planning vaccine education to tailor and share culturally relevant information, as Ms. Vasquez mentioned. We also launched a program to directly send vaccines to community health centers to accelerate the delivery of vaccines to underserved communities and disproportionately affected populations. The invited health centers include those that serve high proportions of low income and minority patients, provide services to rural frontier populations, operate in tribal, urban, Indian health programs, and or utilize mobile vans to deliver services. On the incentive side of things, yesterday the administration announced that we will increase Medicare reimbursement for administering COVID-19 vaccines to make it easier for more healthcare providers to get it out into the communities and give more COVID-19 shots. And thanks to the American Rescue Plan, the administration will now cover 100% of the cost for Medicaid and CHIP beneficiaries to get vaccinated. This will help ensure that vaccines reach vulnerable communities, and it means that trusted healthcare providers will continue to be on the front lines administering vaccines because we will pay them more for each shot that they deliver. And this is all in parallel to the ongoing efforts to increase supply with our partners. So we are working with Johnson & Johnson, with Pfizer, with Merck to increase production, and also Moderna to increase the amount of doses available. Look, just as it was mentioned, despite the progress, there's more to do. We know that person's zip code is a strong driver of health, so we'll continue to prioritize getting the necessary resources to those areas and communities that have been hardest hit and are at the highest risk. So in the coming weeks, we will work with you to do a couple of things. Deliver vaccines directly to additional community health centers that reach underserved communities, work to double the number of pharmacies participating in the pharmacy program and expand mobile operations. We're working to get vaccines to additional vaccinators in hardest hit communities because we acknowledge that you may not trust the medical system, but you will trust your own physician. And we will continue to increase the number of vaccinators to support vaccine efforts. And then, stories like Victoria's and Elia's are a reminder that there's more to learn. We look forward to working with you to identify barriers to individuals being vaccinated and collaborating to reduce them. So please reach out to us. My role, as you mentioned, is to form these relationships and ensure that your feedback is informing the policies that we form in HHS and across the administration. So I look forward to receiving those recommendations and working with the team here to make sure that they make it into our policies, or that our policies are adjusted to meet the needs that you have identified. So with that, I want to thank the National Hispanic Council on Aging for all you do for so many in need, for all your help in the coming weeks and months, and for all we'll accomplish together. So I look forward to working with you.
Thank you so much, Director Figueroa. I want to remind all of our attendees that if you have questions or comments for our presenters, please type them in the chat box, and we will address as many of your questions as possible during our question and answer session. The slow rollout of the COVID-19 vaccines and the limited supply resulted in the CDC providing recommendations to federal, state, and local governments about who should be vaccinated first. CDC's recommendations came from the Advisory Committee on Immunization Practices, an independent panel of medical and public health experts. ACIP advises CDC on population groups and circumstances for vaccine use. The recommendations were made with these goals in mind: decrease death and serious disease as much as possible, preserve functioning of society, and reduce the extra burden COVID-19 is having on people already facing disparities. But let's hear more from our next speaker, Dr. Lauren Smith, the Chief Equity and Strategy Officer from the CDC Foundation. Dr. Smith brings more than 25 years working at the intersection of healthcare delivery and management, public policy, and public health fields. As the Chief Health Equity and Strategy Officer, Dr. Smith partners with the CDC Foundation's other senior leaders to develop and drive strategic efforts to embed health equity across the Foundation's COVID-19 response activities, with an explicit focus on addressing systemic racism and its impact on vulnerable populations' resilience amidst this pandemic. Dr. Smith will speak about the current efforts taking place to immunize our most vulnerable populations. Welcome, Dr. Smith.
Thank you very much, and thank you for inviting me. And I'm just very pleased to be part of this conversation, because both the issues raised and the solutions that folks have started to share are absolutely essential. And so thank you for letting me take a moment to share some thoughts with you from my role or my position at the CDC Foundation. So if we move to the next slide, we know, and I think Dr. Cruz started the conversation about this in terms of the devastation that the coronavirus has caused on all of our communities of color, and especially, as we're talking about now, the Latinx communities in the U.S. The structural racism, I think we have to be clear and talk about that as it is that increases both the exposure and the illness and, unfortunately, death from COVID-19. Those structural processes and problems were in place long before COVID-19 came to be. And so those of us who work in this area, including, I think, everyone on this panel, would have predicted that this kind of disparate impact would happen, because we know these other structural issues are in play. We know that the economic fallout has been a heavier burden for communities of color in terms of job loss or job instability. We know because of that family well-being has had an issue, has been a problem in terms of housing instability, evictions, food insecurity. I'm sure the other panelists can speak to specific increase in folks needing to go to food pantries, et cetera, because they have so much less financial stability than they did. And then, of course, cannot underestimate the social and emotional well-being that has been affected in terms of parents and caregivers of young children who are having increased stress, the children who are out of school and missing the social connections, education, and meals, and the students that are missing what they have, but the seniors and the elders who are missing the contact with their families, or who might be feeling isolated because their families aren't able to sort of connect with them. So the process, or the degree to which all of these experiences have been felt, and especially felt in the Latinx community, I think is really important. Next slide. So Dr. Cruz and others, I think, have alluded to this, but I just wanted to, this is data that's, a couple months old, but I think the ratios are pretty accurate still, unfortunately, which is that Latinx persons have more than 1.5 times the cases, the number of cases. They have 4 times the rate of hospitalizations compared to white non-Hispanic people. They have almost 3 times the rate of deaths. So when people say this is, hitting, communities of color hard, this is why. Next slide. I want to take a moment just to talk about the vaccine, since we're going to be talking a lot about the vaccine. I wanted to share some information about it, and I'm sure Phyllis Arthur will, could share even more. But what I wanted to emphasize is that despite the fact that there's been some, I would say, perhaps unfortunate or incomplete conversation about the effectiveness of the Johnson & Johnson vaccine, I wanted to show you the data here that I think is most critical. One is that all 3 of the vaccines that we are so fortunate to have access to are highly effective against death, which of course is the ultimate terrible outcome. They are also, all 3, highly effective against severe infections. Those are the kinds of infections that would lead to hospitalization, that would lead to potentially long-term sequelae or long-term, after effects. You've heard about the folks who are called the long haulers who have continued, effects. But there is a difference that was documented in terms of against all levels of infection, and one thing to consider is that the Johnson & Johnson vaccine was happening, or the time of those trials there was a much higher rate of COVID vaccine than when the other 2 trials were happening. But all that is to say, the main thing I would want to sort of emphasize for folks who are attending and for folks who want to have conversations with their elderly relatives is to not wait to get a certain vaccine, that whatever vaccine is available is the right vaccine to get, because they are all highly effective against both death and severe infections. So hopefully you can put that part to rest and not have people feel like they don't want to get a particular vaccine because there's some story that is not as effective. Next slide. Okay, so this was as of when I made these slides, this was last week. So, there's good news and other news. The good news is that there's, at this point, and it's even higher now, almost 66 million people in the US have received 1 dose. 35 million people are fully vaccinated. That means they've either received 2 doses of the kinds of vaccines that need 2 doses, or they receive 1 dose of the kind that needs 1, the Johnson & Johnson vaccine. I want to call your attention to what I've circled here in yellow, which is a population over age 65. So there's been 33 million elders or older adults who've gotten a vaccine, and almost 18 million of them are fully vaccinated. And when we look at the overall population, or the who are in that age range, 61% of the population above 65 have gotten at least 1 dose, which is really amazing and something that we should be excited about. Next slide. The issue, of course, is that there has not been, as many folks have already alluded to, the kind of equitable vaccination uptake or administration that we'd want to see, especially because we know that these populations of color have borne a disproportionate burden of the adverse impacts. So here, this is data that's from the CDC .gov COVID tracker, which you can access at any time. Again, this was as of last week. And It's based on almost 65 million people getting at least one dose, as I mentioned. The issue here, and I think, I can't remember who brought it up, but someone has already raised the idea that race ethnicity was only available for about 53%, or just over half of the folks for whom data was reported. So we're going to have to come back to that. But what you can see here is that of the data, of the information for folks who it was reported, about 8.5% of the vaccinations were going to Hispanic or Latinx individuals. Now that's in comparison to, of course, the overall U.S. population that's 18%, and the population for 65 and older of 16.5%. So if we were just looking for straight parity in terms of proportion of the population, you would expect that to be closer to 17%. But if we were also then looking at like who has borne the biggest brunt of these conditions, we would obviously want it to be even higher because of that. As you can see, although we're not speaking about it here, the Alaskan Indian and Alaskan Native groups have the lowest proportion, and they too have had, as I'm sure you're aware, exceptionally high rates of illness and disease, as have African Americans and Asians and Native Hawaiians as well. So next slide. So what does this look like? I wanted to give you just a taste of some of how this is playing out in different areas around the country. So this is in Los Angeles County. This was as of the beginning of February, so I'm hopeful that this looks different now. The proportion of the 65 and older who had received at least one dose in Los Angeles County, 14% of the Hispanic population have received a dose, even though Latinos make up almost 50% of LA County. Next slide. When we look at, this is looking at a map of vaccination sites. This is in DeKalb and Fulton County around Atlanta. And what you can see here is in the darker sort of orange brown areas have a higher proportion of white non-Hispanic population, and you can see that there's more clustering of the circles of the sites in those areas compared to the lighter gray and darker gray areas where there are far fewer vaccination sites. So this is, I think Dr. Cruz, you talked about location and transportation and geographic distance that has to be traveled, and this gives a sense of that just for one metro area. Next slide. So how does inequity get built into the system? And this was I think a really interesting ProPublica article that talks about I think all the things that you all have already mentioned. So I don't think I have to go into it, but access to the internet, not having cars, not speaking English, those who are undocumented or who have legal status that's unclear, or who might be in mixed status families, might have reluctance or reticence to be able to seek out that as well. Next slide. So what specifically increases the risk for Latinx communities? And I think it's really important to break this down because I hesitate to even say this, but I remember a news kind of report of when this data, as you remember, when the data was first coming out about Black and Latino communities having increased rates of cases when that was first coming out. Because remember, we didn't even know that initially. It was all sort of anecdotal. It took a while for us to get that data. There was one comment about, well, maybe there's something about Black and Latino communities or populations around hand hygiene, like they, don't know how to take care of hand hygiene. And I remember hearing this and thinking, I was flabbergasted for once, and almost it's not easy for me to be speechless, but I was pretty much speechless because like, you've got to be kidding me. There are so many structural reasons why Black and Latino families, have these issues. So, it's not about not knowing how to wash your hands. So, in terms of discrimination, the occupation and work conditions, you can just go to the next slide. I'll try to go through this a little bit quickly. There's, documented continued discrimination in healthcare, housing, education, criminal justice, employment, financial services. Those structural things put families and communities at risk because it limits their access to the things that end up protecting and are necessary for creating health, period. The occupation and work conditions that folks live in that have to, sort of accept in terms of having essential work, being in close contact with the public and co-workers, the inability to work from home. I think probably everyone on this panel looks like they might be working from home or have the capacity to work from home. These essential workers that we're talking about don't have that luxury, and so therefore they're put in harm's way. Healthcare access and utilization, I think we talked about. The lower paying jobs with like work flexibility, that ability, like I can't stay home from work because if I do stay home from work, even if I have symptoms, I'm going to lose out on income I need to maintain my housing, my family, my food, et cetera, all those different things. And then lastly, just, issues around housing conditions and limited housing options, which aren't random, but are part, again, of that systemic discrimination about who gets to live where. And that ends up forcing but of course some is a preference in terms of multi-generation households. But the sharing and the crowding of households because of the inability to sort of afford better housing is absolutely increases the risk of a communicable disease. Next slide. So in speaking around older adults, I think it's important to also then think about, layered on to what I just talked about for challenges that face communities of color, in particular the Latinx communities, are issues that older adults face, including the likelihood of being homebound, of lacking transportation. Depending on where they live, they may or may not have the family support to help them find the vaccines, as we heard about from Migdalia. The access to internet, the English as a first language. And then we haven't talked as much about it, but for older adults living in remote or rural areas where they have even more isolation. And then there's a special part about being older in terms of cognitive impairment or decline, mobility challenges. We talk about not being able to use the internet. Maybe they can use it, but like they have vision challenges or hearing or other disabilities. So all of those I think are really important considerations that one has to layer on to thinking about how do you get to older adults. Next slide. Oh, great. So guidance for vaccinating older adults. So, this is general good practice, I think, in working with any community, but I wanted to just take a moment to highlight several of the areas or issues that I think are particularly relevant for older adults, and happy to share this picture, which is from the Illinois Migrant Council, who is an example of a group that's been, I think, doing really amazing work to get Latinx older folks tested and then vaccinated. So if we go to the next slide. Working with partners, there's such an array of partners, some of whom I'm sure public health departments, as an example, think about, others of whom maybe not. So senior nutrition programs, paratransit services. I think people are increasingly understanding the importance of working with tribal organizations and faith-based organizations, but cultural groups that serve as hubs in a community, veterans groups. There's a wide array of potential partners, and I think it's incumbent upon public health departments to not stop at with the more obvious groups that one might have been used to working with. Next slide. Thinking about the convenient and accessible locations, here are some examples that folks are working with and thinking about. Especially want to call attention to residential care facilities, elder housing complexes. I live outside of Boston, and Boston definitely has specific residential buildings that cater to elders, and so needing to make sure to reach out to them, as well as, of course, to senior centers and adult day centers and those sorts of things. Next slide. And having the information be accessible and trusted, I think Phyllis Arthur, mentioned that. Certainly having multiple languages, we talked about having call centers. We also have to think about other kinds of accessibility, like Braille or closed caption TV or large text. Again, thinking about the fact that, elders may have other kinds of visual, hearing, or other kinds of impairments. And then, of course, having the trusted messengers like community health workers and promotoras that I'm going to talk a little bit about in a minute. Next slide. So what's working in the Latinx communities? I wanted to at least, we give you, so often we talk about these things and we document the troubles, but I think it's also important to identify some examples of really, I think, excellent and creative work. So first, I showed you that picture of the Illinois Migrant Council. They're involved with information and education referrals. They are specifically partnering with the state health department's equity team and their mobile testing team. So that's an example of I think, a very robust partnership with the state health department. They are also partnering with county health departments and local health clinics. They have also partnering with local Latinx owned and serving businesses to be able to get information out. And they've been helping to staff mobile sites, like the one I showed in that picture. In Indiana, there's the Learning Network of Clinton County, which is a rural county. They are specifically using a promotora program, and they have set up a Spanish language call center. And not only do they help people navigate the system, but the promotoras and the folks that are at the call center prep the folks calling for the vaccination experience. So they go over what are they likely to expect? What are they going to encounter? What do they need to bring with them? How should they answer any of their questions ahead of time? So it's not just about getting them hooked up with a vaccination slot. It's about, helping them with some, but as a pediatrician, I would call, anticipatory guidance on what it's going to be like. And then, of course, translating outreach materials. Next. In North Carolina, we have the El Centro Hispano, again, has a strong promotora program. They screen for eligibility. They assist with appointments, similar to what was happening in Indiana. And they go on to be on site to offer advocacy and support of community members at the vaccination site when folks are interacting with the folks who stood up the site. And they provide cultural competency and give feedback to the folks that are developing those kind of sites and outreach. And then in Maryland, the Latin American Community Center has been hosting pop-up community vaccination sites. Again, we see this theme of the promotoras assisting clients. That's really, across all of these. And again, they also are doing one-on-one education when scheduling appointments. And because they are nimble and are able to sort of act quickly, they'll have a situation where the state will say, hey, I've got 2,000 vaccines. Can you set up a vaccination outreach, tomorrow? And they have the networks and the capacity to be able to do that, to turn that around, to be able to get that out to folks. Next slide. Before I end, I just wanted to sort of share that there are a host of resources on the CDC website, if folks haven't explored it, there in terms of posters and fact sheets, stickers, and all sorts of social media content, videos. Next slide. Many of which are specific to the kinds of populations I think that you all would be interested in terms of what older adults would need to know about vaccines, what there might be equity considerations for racial and ethnic minority groups. And as you see on the right here, many of these are, or almost all of them are in Spanish also, also in a number of other languages, but the one around the faith community here, the Consideraciones para Comunidades de Fe, that if you don't know to look for it, you'd miss the fact that there's a little button there that you can click and switch over into Spanish. Next slide. Here's one, an example of resources for equitable vaccination. That's a guide for families, extended families who live in the same household and what folks can do. So we were talking about Latinx communities often having blended or multi-generational families. And so this gives some ideas about that. Next slide. And I'm happy to share with this. This is just a sample of the kinds of resources that are available for older adults. There's toolkits for community-based organizations that are in Spanish. There are toolkits for folks who need extra precautions, like the elderly, and of course there's a whole bunch of information around racial and ethnic disparities. So with that, I think that's my last slide.
Thank you so much, Dr. Smith. That was all very, very informational. And we've gotten some great comments in response to your presentation that we'll share in our question and answer session. If you have any other questions or comments, please use the chat box for that, and we will address those in our last segment. So people of any age, even healthy young adults and children, can get COVID-19 and face devastating consequences. People who are older or have certain underlying medical conditions are at an even higher risk of getting very sick from COVID. To stop this pandemic, we need to use all of our prevention tools. Vaccines are one of the most effective tools in our toolbox to protect our health and prevent diseases. But how do we know who is truly at highest risk for COVID-19 and thus should be prioritized for the vaccine? Our next speaker is Dr. Henry Pacheco, a family physician and the National Hispanic Council on Aging's medical advisor. Today, Dr. Pacheco will speak about how we determine who is at the highest risk and should be prioritized to receive the COVID-19 vaccine. Welcome, Dr. Pacheco.
Thank you so much, Christina. Thank you so much, Dr. Cruz, for allowing me to participate in this wonderful webinar. Let me go ahead and start with a brief introduction to what the situation, what has brought us to the situation. You know, the history of this family of viruses really starts in the 1960s. In 1968, this is when this family of coronaviruses were first identified and probably even visualized. I probably had electron microscopes by then. And then we had some pretty scary events related to coronaviruses. In 2002, the SARS acute respiratory syndrome caused significant alert in many countries. 10 years later, the MERS, the Middle East respiratory syndrome appeared, which also caused significant alert. So it was obvious that there were significant risks to worldwide health beginning to develop and could sprout anywhere. We've had these outbreaks of Ebola in Africa, and there have been hemorrhagic fevers in South America as well as Africa. So there's been plenty of warnings that something catastrophic can occur. Now, in order for the world or for the nation to be prepared to mount an effective defense against this, a lot has to happen. You have to identify the agent, the urgencies, contact key agencies nationally and internationally, develop jurisdictional leadership structures, conduct epidemiological science-based studies, determine the proportion and the population that is going to be affected by this emerging risk, engage stakeholders, academic centers, health centers, medical centers, public health people, advocates. These are one of the large, some of the large components of what has to happen in order to mount an effective defense when you have an outbreak like we just had experienced. You know, we have to develop also the political support, and at every level, the political support at the national level, international level, at the regional level, and down at the county level, at the community level, a support for a unified response where everybody has a role and everybody plays some role in detaining a disease that can really cause disasters, death, and morbidity in populations. You also have to study accessibility and the cost effectiveness of various interventions, be it prevention and treatment, vaccines. All of these efforts are aimed to stop a virus from progressing. When limited treatment and prevention resources are available, there's also a need to determine, priorities based on the resources, based on epidemiological findings, demographic profiles, who is being affected by this, who do we need to focus on first, or who do we need to focus? The capacity of the system in general and getting buy-in of the populations, conduct financial analysis. It's an enormous enterprise. Now, I think in around 2006 or so, significant efforts have been put in place to have the nation's readiness in place. There was a national strategy for the influenza pandemic, and it was under President Bush. Similar efforts were under President Obama. These were efforts to try to have a disaster preparedness at the national level and international level. Unfortunately, many of these were either dismantled or underfunded, and then in 2009, we are facing this crisis of its enormous proportions. I put the brief timeline of the COVID-19 there. It's not meant to be read, but just to give us an idea of how rapidly this infection spread across the world and some of our responses. The timeline is not meant to be all-inclusive; just highlights some things. And on the right, you have a graph that details some of the daily confirmed cases of this disease, of this pandemic. As I mentioned, in somewhere around December 29th, the Ministry of Health of Wuhan province in China alerted about the outbreak of an unknown pneumonia. So in December 2019, made it to the World Health Organization that put out the alert that there was an unknown pneumonia, possibly viral, in developing in Wuhan, China. Soon after, in January 21st, we had the first case of this disease in Washington State. Now, if you can see the graph on the right side, how this thing progresses month by month, and how the number of cases grow. And then by February 6th, we had the first fatality. February 6th, the first fatality of COVID in the U.S. So on and so forth. It continues. The CDC declares this a pandemic. In March, President Trump declares it a national emergency. And by May, we have Operation Warp Speed, which was a public and private partnership initiated by the Trump administration to develop and accelerate the development of vaccines, therapeutics, diagnostics. So this was an attempt to put a stop to this. However, by May 28th, we already passed 100,000 deaths in the nation, and an amazing number considering that the whole war of Vietnam had 50,000 deaths. In any case, it's July when World Health announces that the virus can be airborne, which means that we can actually inhale this thing through our mouth, nose, and mucosas in general. Very scary declaration. And I think something like that by April is when officially the CDC started promoting the use of face masks. And, no sooner, by August, COVID becomes the third leading of cause in the United States. Of course, we are all we're focusing on the United States. In the meantime, horrendous things are happening all over the world. Terrible things. Even in Europe, advanced countries, not to mention Latin America, Africa, and all of these countries are just suffering tremendously because they have less resources than what we have in this country. So here we are. By March 2021, we have 29 million cases in the United States, over 500,000 deaths, and, well, I think up to 100 million vaccine dosages already distributed. But you can see how the curve has started going down drastically in after March. Next slide, please. So the question is, how do you put up a defense? What strategy do you develop to allocate resources such as treatment and vaccines? There's not much treatment for the virus, but some antivirals were being developed and were being used, but there is yet no vaccine. But if we initially look at the demographics of this in this graph, we see that at the beginning of the month, at the beginning of the epidemic, minorities, African Americans, Hispanics, Asian, make up almost 60% of those being affected or dying, let's say, share of deaths of the population, way out of proportion to what their representation in general population is, which you can see in a little band on the right side. Gradually, you can see that the number of minorities, let's say, is coming down. The number of whites infected is increasing. Nevertheless, it's still this disease is affecting minorities, African Americans, Hispanics, Asians significantly, and the reason is why. Is it something intrinsic about their racial and ethnic makeup that explains this? It's hard to say. Everything has been considered. Is it predisposing conditions that African Americans, Hispanics have? Hypertension, diabetes, asthma. Physicians knew that folks with these predisposing conditions were suffering tremendously mortality. Is it social? Is it living in close quarters, therefore infecting each other very easily? Is it occupational? These folks work in industries where there's a lot of contact with the general public. Are these the causes? And if so, how can you stop it? What can you do about this? Next slide, please. Next, this other slide is kind of interesting because, as we know, if you look at the share of deaths in proportion to the population, we see that the over 70 comprise over half or over 50% of the deaths, and if you take into account the over 60% of deaths, yes, their proportion in the population is a lot smaller. So this disease is definitely killing off older adults. Now, if you look on the right side and you see the cases and the share of the population, the cases are overly represented, especially, or at least slightly overrepresented in the 20s, 30s. So what does that mean? That means that these young people are getting the disease and passing it to the older adults, and in whom there is a greater mortality. So should you devise a vaccine, and should you focus on this young population on vaccine and vaccinate them first because they are the carriers? Those are some of the things to consider. But as we know, there are problems with the vaccine in the sense that we know that it prevents you from getting sick, but it may not be effective in eradicating the presence of the virus in the mucosa. Therefore, somebody vaccinated can still pass it to others. But these are some of the conditions. Next slide, please. Social determinants have, of course, been taken into account in trying to formulate this attack, this control of this everything, educational, the educational profile of those being affected, the deaths, the racial ethnicity, educational profiles, veteran status. These are some of the things that have been studied in trying to develop to see where do we mount an effective attack. Next slide. Next slide, please. Can you pass the next slide? Great. Well, in the need to develop guidelines, Dr. Smith, I believe, mentioned a lot of the process of developing the vaccine guidelines and priorities. But in any case, you've had a contribution of tremendous centers, Johns Hopkins, National Institute of Health. I'm highlighting here the National Academies of Science, Engineering, and Medicine. They, this group of members, which is highly regarded scientists, and scientists, I don't mean just clinical scientists, but I mean scientists in all kinds of fields of demographics, psychology, studied this issue, and they put together some guidelines that they thought it would be good to implement. It had these phases. They developed these phases, and they put the populations in these phases that should be given a priority. And this was based on tons of study materials and presentations. These are not five guys on the table. Similar efforts were done by other agencies that were also contributed to this effort of developing a guidance once a vaccine was developed. Next slide, please. So we had the pharmaceuticals coming out and having developed and tested vaccines. They threw it through, the various testing mechanisms. And finally, they presented their findings to the FDA, the Federal Drug Administration, to see if the FDA would authorize and approve the use of this vaccine. So the FDA authorized and approved, Pfizer and the Moderna, and more recently Johnson & Johnson. They approved the use of this vaccine. So this goes on to ACIP, the advisory committee that meets publicly to review all the data, clinical information, ethical issues, safety, effectiveness. Once again, this committee gets tremendous feedback from the whole spectrum of the American population. You have advocates, racial and ethnic groups are represented by their organizations that advocate for them, various scientific communities. It's innumerable the number of agencies that contribute to advise, to provide advice and recommendations to the advisory committee. So once the advisory, the SAIP membership votes to recommend or not the vaccine, as to who should be offered, and makes the allocation recommendation, this goes to the CDC, and the CDC sets the vaccination schedules based on ACIP recommendations. Once the CDC director approves, they're publishing the morbidity and mortality weekly report, and it becomes official. This is what most physicians, clinicians, healthcare providers in various states refer to. And each state then sets priorities about who gets vaccinated based on these recommendations and their own realities. And right below, I have a website that can tell you more or less who is, that you can click on and see how each state has developed their own priorities. Next slide. Of course, all of this works fine as long as we are working with facts, with scientifically proven and evidence, and if we're working with factual information based on scientific, ethical, and public health principles, right? And we're definitely not prepared to have interference in what the American population expects to be a fair, equitable, and fact-based process. But one of the threats that has come up lately in this past few years, and this is not new, by the way, it has happened before, is the politicization of our public health agencies. I think just last week I got this on CNN, which is a review of the CDC's guidance that describes that some of the guidance was not grounded in science and was not free of influence, and some documents made it there. So this is a real threat because of how much we depend on agencies such as the CDC and all of these public health agencies to develop actual science-based principles for setting priorities of anything that has to do with American health. Next slide.
Thank you, Dr. Pacheco. So much for your. Yeah.
A brief, fast overview. Thank you so much.
Thank you. Let's welcome our next speaker, Mr. Denny Chan, the Directing Attorney for Equity Advocacy from Justice and Aging. Mr. Chan is responsible for developing and leading Justice and Aging's strategic initiative on advancing equity, which aims to center the organization's advocacy strategies and projects on issues directly addressing systemic inequities faced by older adults of color, older women, LGBTQIA2S older adults with disabilities, and older adults who are immigrants or have limited English proficiency. Today, Mr. Chan will speak about the fair distribution of the COVID-19 vaccine. Welcome.
Great, thank you everyone. Thank you so much to Dr. Cruz and your team for having me here. I'm really excited to be talking about this very important and timely topic. So a quick note in case you don't know about us at Justice and Aging, we're a national legal advocacy organization that is dedicated to using the power of the law to fight senior poverty and fight on behalf of those who are most vulnerable. Next slide, please. And we have an express commitment to diversity, equity, and inclusion at Justice and Aging that allows us to acknowledge systemic racism and discrimination, to address the enduring negative effects of racism and differential treatment, and promote access and equity in all of our programs, as well as an internal commitment to recruiting and retaining a staff that is, and a board that is diverse along many different types of diversity. So I want to start off by talking a little bit, a couple of the other previous speakers had talked about some of the disparities, and I want to focus really on the disparities that hit older adults of color specifically, because you saw some data around older adults, you saw some data around communities of color, and I'm going to try using CMS data to piece together some different pieces. So starting in June of 2020, CMS last year began releasing data about the impact of COVID-19 on Medicare enrollees, including dual eligible beneficiaries who are by definition low-income older adults primarily and people with disabilities. And what we saw in the data was that dual eligibles, people who are low-income older adults, are 3 times more likely to contract COVID as opposed to people who are just on Medicare and not on Medicaid. In other words, don't have low income. And they're almost 3.5 times more likely to be hospitalized from COVID-19. Many Medicare enrollees of color experience higher rates of COVID-19 hospitalization than white Medicare enrollees. So what you can see really here is that intersection. You can see the intersection of age, of class, of race, all working together to create these disparities. Next slide. And so here are some points that I want to lift up, and I thought a visual would be more effective to show it. So if you look specifically on the left-hand side, these are hospitalization rates among dual eligibles, and I broke it out by different populations of color. So we have the white bar is white people, the black, the orange bar is black, gray is American Indian, Alaska Native, and yellow is Hispanic. And what you can see across the board is that these 3 populations, American Indian, Black, and Hispanic dual eligibles, are more likely to be hospitalized from COVID-19 compared to white dual eligibles. So again, even when you're controlling for class and age, because those people are the same bucket of age, same general socioeconomic status, you can see that there's something happening in the racial, that is being motivated by race in what's happening among infections and well, in this case, hospitalizations. Next slide. So what are the challenges? And a number of the speakers previously have hit on them. I'll say at first thing as a preliminary note, we don't have control over COVID-19, right? We can only control our own behavior in terms of wearing masks, following the public health guidance. We don't have control. We weren't prepared, honestly, for COVID-19 to happen. But I think what's even more troubling is that we knew of these inequities before COVID-19. We knew that there were language access issues. We knew that there were disparate outcomes in terms of health disparities. We know that homebound seniors sometimes can't get out of the home. We know there are seniors who live in rural communities. And in the planning and execution of delivering the vaccine, we have not seen a systemic recognition that those populations exist and are part of the plan to get them vaccinated. So obviously we can't control scarcity, right? There's very little that we can do. We have our capacity is our capacity. But what I will say is what we've saw, especially early on in the speed under the pressure to speedily roll things out, we saw over-reliance on mass vaccination sites. Who does that target? That targets people who have the ability to sign up, who know about where those mass vaccination sites are, and have the means, whether it's public transit, hopefully public transit gets to those sites, or have the personal transportation to get to those sites. And so what we see, and I'll show you in a little bit, is that that has now resulted in disparate outcomes, even in terms of vaccine distribution. We also saw a number of other speakers have talked about this, inaccessible registration and website usage, right? I know that, for example, in Orange County, California, they were primarily taking registration over an app on a cell phone. In other words, if you didn't have a cell phone and didn't know how to download the app, you weren't going to get an appointment. So of course, what did many older adults do? Rely on younger caregivers and family members to help them through the process. But that's not the kind of situation we want to set up, right? We want to empower older adults, no matter what they look like, to be able to get to a vaccine themselves successfully, particularly in light of the earlier data, that they are more at risk of death. I mean, that is clear in all the data across the board, regardless of race. There are some more disparate outcomes in terms of race, but you are more likely to die from COVID-19 as an older adult. And then I will also say, you know, the vaccine logistics has been another issue. One, we should be really grateful that we have now 3 authorized vaccines in record time. No one thought it was gonna take this short amount of time. Everyone thought it was gonna be a much longer process. We should be really happy and celebrating that. But I will say, at least with respect to the first 2 vaccines, Pfizer and Moderna, the fact that there were cold chain storage requirements and that it's a 2-shot dose presents some logistical barriers, particularly if you're talking about reaching homebound individuals who can't get to a mass vaccination site. It is just logistically much more complicated to administer. That is now kind of changing given the authorization around Johnson & Johnson, but it does remain a challenge to really be able to transport the vaccines in a way that preserves their efficacy. And then finally, a number of other speakers have already highlighted vaccine confidence or vaccine hesitancy as an ongoing issue. Next slide. So here's what I was trying to get at earlier. We not only see inequities in the COVID infection and hospitalization data, we see it playing out in vaccinations. And this is what we can control though. We can't necessarily control and end racism to prevent the disparities in infections, but we can control how we administer and set up a vaccine distribution system that really centers equity. So I will say this, as a first and foremost matter, there is no good intersectional data. We have data on communities of color, we have data on older adults, but if you're talking about older adults in communities of color, we don't have good data. I will lift up 3 jurisdictions that we know of that provide that level of data. South Carolina, Washington State, and Los Angeles County. But if you're gonna ask me in Alabama or anywhere else in the country, New York, California as a state, how we're doing in vaccinating older adults of color, I can't tell you. We don't have that information. It's not publicly available. But what we do know in the 3 places that have made it publicly available is that, as you would suspect, a reliance on a one-size-fits-all approach has led to inequitable outcomes in vaccine distribution. So we see in South Carolina, and they're not, for whatever reason, reporting out they're not reporting out other than white and black, is that the uptick in vaccine distribution among white Americans 65 and up is significantly higher than Black Americans. The same is true in Washington State and Los Angeles. And these numbers, I believe, are as current as of last week. But because a lot of the data is capturing the 2-shot doses, it does not include the Johnson & Johnson, which is why it says percentage of 65 and up with 1 dose. So what we can see from this is that our system has been set up to create these outcomes. So on the next slide, I think what I'm going to try and get to is some recommendations on how we can change that, turn that around. Number 1, we need to create as many channels and sites for vaccination as possible. That involves working with a number of the people who have already been identified, community-based organizations, faith-based organizations, in language, not just online, You know, these are all solutions that we knew about beforehand, but weren't actually implemented in the planning. Ensuring that there are multiple ways to register, ensuring that the hotlines have, not that you just have a hotline, but that it's robustly staffed in language as well, right? I mean, we can't assume that older adults are a monolith and that, you know, when they call in, they will all only be speaking in English. Just like when you translate things into different materials, you want to, or different languages, you want to make sure that some of that is available in large print for older adults who are limited English proficient. And then it's really important to make sure that the process is accessible both with respect to physical accessibility and transportation, as well as language access. There are requirements under federal law for both of those things. And then finally, I'll say this, and then I have to hop off, unfortunately, for another conflict, another commitment, which is, I think this is a real good opportunity to focus on cross-movement coalition building. You know, I've recently been in a lot of conversations about you really need to focus on prioritizing older adults. And everyone says, well, that's obviously what you're going to say because you're serving justice, you're the representative from Justice and Aging. And I actually think one way to think about it is if you're thinking about saving the most number of lives, the 75-year-old farm worker is going to benefit from prioritizing older adults. The 70-year-old retiree is going to benefit from prioritizing older adults. The 65-year-old person with multiple chronic conditions is going to benefit from prioritizing older adults. This is really an opportunity to see that older adults are part of all of our communities and in a way that prevents us from getting really bogged down in a turf war about who is most at risk, because we know the data says that older adults are most at risk. And so part of it is recognizing the universality of aging across all our different communities. So that was a whirlwind and a lot of information, but I think, you know, everyone at NHCOA, the team, and unfortunately I have to hop off, so I can't stay for questions and answers. I think if I have one more slide, it might be my email address. And so people might be able to reach me at my email address there. So thank you so much for having me, and this was a wonderful panel. Thank you so much.
Thank you so much, Mr. Chan. A surplus of demand for the vaccine and a low supply, coupled with health inequities and disparities in resources, have created a moral and ethical dilemma around vaccine allocation worldwide. Community-based health clinics are trusted, accessible, and vital to vaccine rollout for vulnerable populations, including older adults and those living with chronic conditions. For example, La Clínica del Pueblo is a health clinic that reaches Hispanics and Latinx who would otherwise have limited access to health care. La Clínica del Pueblo is one of the few local health clinics where vaccines have been administered to Hispanics living in the DC metro area. Our next speaker is Dr. Suyana Linares Baker, Interim Chief Programs Officer and Community Services at La Clínica del Pueblo. Dr. Baker is responsible for overseeing the design, implementation, and evaluation of programs that are culturally and linguistically grounded. Her portfolio includes oversight of the Community Health Action Department and the Health Equity and Language Access Initiative, oversight of La Clínica's monitoring, evaluation, and reporting systems, and program development to reduce health inequities affecting the local Latinx community. Today, Dr. Baker will highlight the health clinic's perspective on the allocation of COVID-19 vaccines. Welcome, Dr. Baker.
Thank you, Christina. Thank you, Dr. Cruz, for the invitation. Happy to be in a panel also with Dr. Pacheco. We've been sharing some of our struggles in DC, so we're kind of neighbors here. But I was very, very happy that you all included the health center perspective in the discussion, right? And I'm here to represent probably a very teenager Federal Qualified Health Center. I mean, as La Clínica history, we started in '83 as a volunteer-run clinic in 2007 because of the influx of funding to serve the people living with HIV. La Clínica, this is our second pandemic. We did HIV before, and we consider that a huge struggle that our population suffer from too. La Clínica became a Federal Qualified Health Center to be able to manage rand-wide funds. Next, please. Just to give you all, for those who doesn't know La Clínica mission is to build a healthy Latino community in the DC metropolitan area. Our vision includes this idea that healthcare is a human right, is not a benefit or a privilege. Every single person should have access to healthcare, and our values is based on health equity, community, quality care, perseverance, enthusiasm, and collaboration. Next, please. This is the population we serve. This is for those who also don't know us, 91% of the people that we serve are Latino, Latinas, 80% are immigrant, predominantly from Central America, El Salvador, Honduras, and Guatemala. The Northern Triangle is the biggest, but with El Salvador is our country. If you think about who is who makes us, that's actually the Latinos in Washington, D.C. comes a lot from El Salvador. If you had the opportunity to know the story about the Latinx community in D.C., the El Salvadorians are the majority. 35% of the people we serve is uninsured. 83% feel more comfortable communicating language other than English. 84% have income at or below 200% of the federal poverty line. 54% are live in DC, 44% in Maryland, and 2% in Virginia. Next, please. La Clínica has, as its approach, combined 4 areas. One is primary care. The other one is mental health substance use. And for that, we have 2 special programs. One for people who are substance use, dealing with substance use. And Mi Refugio was for a school-based program. We have health equity as one of our components that include advocacy and linguistic services, and community health action, that's our community health department. And we have 3 special programs. One is Entre Amigas, that's gender-based violence prevention. The other one is Empoderadas, is our LGBTQ affirming health program, and health promotion that does out of our chronic disease and prevention. Just to give you this idea of what we are. Next, please. Our core elements, we have 4 sites in DC and in Hyattsville, Maryland, and we have a combination of a clinical site with community-based sites that are not clinical, but promote health and create safe space for people to get close to the health system before really going to the clinical site. And next one, please. And this is the core elements. I mean, we believe that we should provide high quality, culturally sensitive, patient-centered, and trauma-informed care to uninsured and underinsured patients. We believe in integrated and co-located services. We coordinate primary mental health care with care coordination and peer-based health education. And we have a strong component that's based on community health action and health equity and advocacy. So this is us, and we're invited to be here today to give a perspective on the COVID vaccine. So the next, please. I think one thing for us to understand, and I think other panelists spoke about that too. If we don't have vaccines that get in all neighborhoods at the same time, that people can feel comfortable to access because they trust the venue can vaccinate more than one person at a time. So it has to be venues that people have an influx of people coming, feeling comfortable to be and get vaccinated and go home. Having a calendar of vaccination that goes with education, why you should get vaccinated. And we should troubleshoot barriers like cultural, language, access, technology, etc. We cannot have a system that's just one shot, just one way to get vaccine. So we have to have multiple entries so people feel close to the vaccine. If you have to prioritize, you should have prioritized people who are more at risk. We have this idea that the best vaccine and the fair vaccine process is when the vaccine gets to people instead of having people to fight to get to the vaccine. We are not talking about a privilege. We're talking about something that we should convince people to get there. So we should have everybody getting that and feel like on the corner, you have some flag saying, get your vaccine here. And you on the way home or going back from work, you're going to go in front of something who says, get your vaccine here. And then you're going to get vaccinated. This was going to be the best way. Federal qualified health centers and community health centers, the next please, are very, it's a good setup for that, right? And I would like to remember here that the Federal Qualified Health Center movement in US comes from the 60s on a war on poverty, who really at that point believed that primary care was very important to take people out of poverty. And primary care is better delivered in community-based centers where people feel comfortable and trust the center. However, in US in 2020, we have 43% of the population, 43% of the adult population, 19 to 64, uninsured or underinsured. So half of the population in US don't have a trusted healthcare provider. So, and this is a problem when we think a pandemic that relies on vaccination, where people should trust a healthcare provider or a healthcare delivery system. We do not have in US yet, and we do believe health centers should be multiplied because La Clinic is very small. We serve a very small amount, but we are a movement. We are part of a movement. There's many other like us, and this is an incredibly good model to deal with public health issues or mass health issues that we're dealing now. Next slide, please. So this is what La Clinic is trying to do and what the Federal Qualified Health Centers are capacity to be part of. So we are a safe space for our community because we provide care with cultural competency. We provide language access in our case because we need to provide language. We serve the Hispanic immigrant community. Community health centers are better for health literacy because you have time to go back there and it's close to where you live, and you go back there if you do not understand what your provider told you or if your specialist told you. We are rooted on the community, so many times people, La Clinica, for example, 90% of the La Clinica's employees are immigrants. So we are immigrants serving the immigrant community, so people feel rooted, right? We feel that we're part of the same neighborhood. And also community health centers are able to do advocacy because we can represent the community that we serve. Also, as I mentioned to you, there is 2 educational materials that La Clinica just provided for our community, and this importance that we're having now. And I think it's the last thing that I want to say, and I can be open for questions. We should not educate people for vaccine if there is no access to the vaccine. This make people very confused. You're telling people that you should get vaccinated, and then people try to get vaccinated, and there is no vaccination available. This is driving everybody so anxious. People are getting very anxious from I don't want to have the vaccine, from I want to have a vaccine, but I cannot get through the system and find a vaccine for me to take. So we should be very careful how we promote this. La Clinica has received vaccines directly from the DC government. Soon we're going to get vaccines directly from them, the federal government. And so far, since March, we did not vaccinate all our 65 years old, 65 and older around us because not enough vaccine. So to give you a perspective, how hard it has been to have access to vaccine. So we are trying to do as much as we can, educate and provide access at the same time, because if not, you make everybody very unsafe. Thank you for listening, and I'm open to answer any question that you all have later.
Thank you so much, Dr. Baker. Preventing inequities in the distribution of COVID-19 vaccines is important to ease the disproportionate impacts of the virus for our people and to prevent exacerbation of racial health inequities. Current plans and frameworks are falling short. Elected officials and public health departments need to engage community-based organizations to ensure that they can successfully vaccinate those most at risk. A recent report by the Kaiser Family Foundation shows a consistent pattern of Black and Latino people receiving smaller shares of vaccines compared to both their shares of COVID-19 cases, deaths, and their shares of the total population. Our next speaker is Dr. Erica Blackshear, who holds the endowed John B. Francis Chair at the Center for Practical Bioethics in Kansas City, Missouri. She is a research professor in the Department of History and Philosophy of Medicine at the University of Kansas Medical Center and holds an affiliate faculty position in the Department of Bioethics and Humanities at the University of Washington. Dr. Blackshear's work focuses on questions of responsibility and justice raised by health inequities and the role that deliberate deliberative democracy and civic engagement can play in advancing health equity and social justice. Today, Dr. Blackshear will speak about the democratic deliberation and the importance of including communities in vaccine distribution planning. Welcome, Dr. Blackshear.
Hi, everyone. Thank you for the invitation to be a part of this esteemed panel. I truly appreciate the opportunity. I just want to make sure, can everyone hear me? Great.
Yeah, we can hear you.
So I know we're running short on time, so I may skip over a few slides to make sure we have some time for questions. I'm going to talk with you all today about the ethical significance of robust public engagement during times of crisis, including during times of pandemic. And I'm going to introduce this notion, this approach to engagement called democratic deliberation, which is very well suited to bringing the public into discussion around the very complex ethical questions, ethical issues that many of the panelists today have addressed. So I have three objectives, and since I am running short on time, and since I do tend to be a bit of a fire hose speaker, I am going to move quickly, so buckle your seatbelts. I'm going to introduce democratic deliberation. I'm going to identify key values and elements of democratic deliberation, and then I'm going to get to justifying why we should use it, not only in the health sector, but for pandemic planning and response. And just to give you a sense of where I'm headed, this talk will culminate in providing you with an example. We think the only example of democratic deliberation that was used this year to address COVID-19 specific issues and specifically equitable vaccine distribution, which was a collaboration between the New York Academy of Medicine and the New York City Department of Health. So that's where I'm headed. So next, we're already to the next slide. I like the slide changer. They're anticipating my every move. The basic value proposition of democratic deliberation is that people should have meaningful opportunities to participate in important social decisions. This idea is rooted in political theory, it's rooted in moral theory, it's rooted in communication theory, and makes the case in varying ways for an informed and active citizenry that is deeply engaged in its own governance. Next slide, please. Now, these ideas, which are the stuff of many scholarly books and symposia and conferences, have also spawned a wellspring of civically oriented participatory activity around the globe, especially these last 3 decades. There are organizations devoted to teaching people how to deliberate, creating spaces for people to deliberate. Handbooks have been written, books have been written, as you can see, and deliberative experiments have proliferated. There are citizen juries, citizen assemblies, planning cells, deliberative polling, and much more. All are aimed at convening citizens, ordinary citizens, to learn together, to discuss together and debate and weigh in on important issues that affect them, sometimes in ways quite specifically, but sometimes more generally as people, as citizens. Next slide, please. Now, public deliberation has also gained traction in the U.S. health sector. We've seen this especially in the last 2 decades. And it reflects a broader participatory turn in health care, in biomedicine, and public health and health policy. And we see that in some cases, some of this will be quite familiar to you all. It's been routinized. It's become the expectation that we have community advisory boards, that we do community-based participatory research, that health research be anchored in become patient-centered outcome research, if you will. And public deliberation, too, has gained a foothold here. And that's reflected in the fact that some years ago, the Agency for Healthcare Research and Quality, otherwise known as AHRQ, funded a controlled trial of deliberative methods to learn more about deliberation in general and specific deliberative methods in particular. Now, I can talk more about that study and its outcomes in the Q&A if people are interested, but I do want to highlight one outcome, which I think is important to this topic today, which is that they found that in post-deliberation studies, the process was particularly appreciated by racial and ethnic minorities and people of low education and income status. So those people especially appreciated having their voices heard, especially liked the idea of being able to weigh in on an issue that affected them in the context of healthcare in the case of that particular deliberation. And we can talk about that more later. Next slide, please. We still haven't address the question, well, what is deliberation and how is it different from all the other forms of public engagement that are out there? So I'm going to speak to that next. So in broadest terms, public deliberation is a substantive form of public discussion that seeks collective solutions to shared challenges that are value-laden and involve normative trade-offs. We can't do it all, so what ought we to do? It's an ethical question. What ought we to do? The questions that frame deliberations typically take the form of what ought we to do about X, right? So let's flesh that out a bit and look at two definitions of democratic deliberation. Let me just point your attention to this one and this definition. So deliberation aims at producing reasonable, well-informed opinions in which participants are willing to revise preferences in light of discussion, new information, and claims made by fellow participants. Here's another one. Deliberation engages ordinary citizens with diverse perspectives and reasoned and respectful discussion about important social issues in search of well-informed proposals that deliberants will view as legitimate. Okay, so these quotes foreground four things. First, that people in the room should be diverse and have diverse perspectives. It also suggests something about the form of discussion, which is to say that people engage each other as morally serious persons. That is, as people with values and reasons and worldviews that support their viewpoints that they can and will be willing to share. Third, it speaks to what's called the transformative potential of democratic deliberation, which is the idea that people may learn from whether it's the experts or the materials provided or from their fellow participants, from carefully listening, that they might revise their thinking or understand better their own thinking. And finally, it speaks to a much sought after outcome, namely that participants will view the process as fair, regardless of whether they agree in whole with the results, the outcomes of the deliberation. In all these ways, deliberation delivers outcomes that go well beyond the top of mind opinions we get with surveys, town halls, and focus groups. Those are important forms of engagement, but they're different from democratic deliberation. Now, not every question is well served by deliberation. It's best used when one or more of the following conditions obtain: when there are competing and conflicting social values involved, when there are normative trade-offs that have to be made, when the issues being considered are controversial, divisive, or sensitive, when there's low trust, maybe among some social groups or more broadly just in society. We're at a nadir today in terms of the degree to which people trust one another. Americans trust one another and government and so on. And finally, when the issue being discussed, and I hope this has been clear, but it's been latent, so let me bring it out explicitly, when the question requires not just technical expertise, but real-world knowledge, lived experience. So that is when you know you've got an issue ripe for democratic deliberation. Now, as these descriptions and definitions suggest, deliberative engagement is shot through with ethical and what we might call small d democratic aspirations. So let's look more specifically and quickly at the ethical and political values that animate deliberative engagement. Next slide, please. This next slide will sum up much of what I've already said. So let me just make it explicit. Democratic deliberation seeks to create inclusive, fair, public-spirited processes that will in turn help yield three things: a more informed and engaged public, and in the context of healthcare, research participants, patients, caregivers, families, more transparent, fair, trustworthy, and legitimate decision-making process with the ultimate goal of more inclusive, sustainable, and just decisions. Now, there is a worry from the left, a critique, if you will, that democratic deliberation will or could marginalize and silence the views and interests of minorities, those who are poor, the vulnerable, and perpetuate entrenched inequities. So how do we achieve the good outcomes and avoid the bad ones? Well, you do that through very careful deliberation, design, and implementation, which I do a lot of, but which I cannot speak to in a 10-minute talk. But let me just go to the next slide to say that these are some of its basic elements. I don't want to spend any time here, but this speaks to just how intensive the process of deliberation design is, again, working for that ultimate goal of creating an inclusive, fair process and one that will achieve legitimate, trustworthy, and more fair outcomes. Let's go to the next slide. I want to just put this talk in the context of the work that I've been doing very quickly. I won't speak at any length to this other than to say that I have been working in this arena with communities of color and indigenous communities. And I just want to point to this last one, which is this partnership between the New York Academy of Medicine and the New York City Department of Health. They conducted 5 online public deliberations to gather informed guidance with a diverse cross-section of New Yorkers that represented every borough. Over half the participants were people of color. And there the question was, who among essential workers should gain priority to access to COVID-19 vaccine? Now, in this particular case, I was not involved in the design and implementation. I was recruited rather to develop and deliver a plain language presentation, no more than 10 minutes, on various ways to think about distributed fairness. Next slide, please. Again, to our knowledge, let me just repeat this. To our knowledge, it is the only democratic deliberation in the United States. We found one in Australia that was done on COVID-19 issues, that has been done on these issues. And what we found is that New York City participants favored an equity approach to vaccine priority, and they prioritized underlying health conditions and neighborhood vulnerability as risk factors. And those recommendations are now reflected in New York City's Vaccine for All initiative. Those are links where you can find out more about the outcomes and more about democratic deliberation. If we could just go to the last slide. What I'd like to say is that one of the things we learned in doing these online deliberations is that the people who participated in them greatly appreciated the opportunity to learn not just from experts, but from one another, other New Yorkers. They appreciated having their voices heard and their recommendations being seriously considered by decision makers. And they indicated, and I think this is important, that participating in this and having the opportunity to learn and discuss actually quelled some uncertainty, some hesitancy, some worries about the safety and the efficacy of the vaccine. And these sorts of outcomes are not unusual for democratic deliberation. This last slide just speaks quickly to what we've learned from studying the processes of democratic deliberation. We have learned that it can correct misinformation and combat disinformation around whatever issue you're bringing the public together to talk about. It can build public trust. It can promote self-efficacy, collective efficacy, and political efficacy. In other words, it can actually function to empower people. There's been some evidence that it can, by involving people in a substantive way, it can improve adherence to policies and recommended practices. And I'll just end on this last note because I'm seeing the clock, because I've already spoken to those other bullets. It's a way to demonstrate respect for voices that often go unheard. So I'm a big fan of it. There is my email. I'm actually calling in today from my home in Seattle. Again, it was a pleasure to be with you, and I look forward to any questions that you all might have. I know I have questions for some of my fellow panelists that I'm going to be reaching out to later. Thanks again.
Thank you so much, Dr. Blackshear. We did have a question in the box that I think can be directed directly to you. If a jurisdiction is interested in engaging in democratic deliberation to address something like the vaccine allocation, where do they start? Do they contact you, or I mean, is there?
Well, sometimes people do contact me, and that is how I've gotten involved in a lot of the deliberations that I've been involved in designing and implementing. But on the slide, and I don't know if the slides will be shared, there's a link where you can go to learn about democratic deliberation. One of the funders of the New York Academy of Medicine, New York City Department of Health project was the de Beaumont Foundation. And one of the outcomes of that is a toolkit about democratic deliberation. And that second link, you can actually go and get some resources about that. But it's not the only place you can get resources. You can Google democratic deliberation, and you'll find that there are organizations devoted to that, national issues forums, the public agenda, and other places. And you're always welcome to email me at eblackshear@practicalbioethics.org, and I can send you to some resources as well. I will say, I can't underscore enough, and this comes from now some 6 or 7 years being engaged with communities, often underserved, underrepresented, often racial and ethnic minorities, how important the process of designing the deliberation in a very intentional way is to getting good results and making sure people feel included. In fact, an approach that I and we often use, partners I've been engaged with, will combine community-based participatory principles and values to inform the process of democratic deliberation, to ensure that that deliberative process is community, is appropriate for the communities where it's being implemented. I hope that is enough of a starter response.
That's perfect, thank you. And then we've got a question from Father Jerry Maynard, who is a priest, and he asked what kind of toolkits, webinars, handouts, etc. exist for faith communities to utilize to mobilize their congregations, given that addressing public health concerns from the pulpit has shown to be extremely effective. Dr. Pacheco, do you have any insight? Or
yes,
any of our other panelists? Go ahead.
Yes, well, the CDC, for example, has I hate to say this, but there are many agencies that have all kinds of handouts on various aspects of reaching out the community, advocating the community, teaching the community. I mean, not too long ago, I was exploring, and the CDC has a tremendous amount, but there's so many agencies, New York Department of Health. One of the things I would suggest to this gentleman, to the fathers, to let Christina see what you think of it, is for him to send you his email address, and then with a request of what kind of information he's looking for, and then you can send me his request, and I can email you websites where he can download the information that he requests. Would that work?
Perfect. Yes, that's perfect. So Father Maynard, just send me your contact information. We'll make sure to get you those resources. To be respectful of everyone's time, we will address additional questions in the comment section. This video will be posted on our YouTube channel. And so your questions will not go unanswered. We will address them. Unfortunately, we just do not have enough time in this forum to do so. So again, thank you to our sponsors, experts, and every one of our attendees for joining us today for this virtual event. For more information about this event and our upcoming virtual events, please visit NHCOA's website and our social media channels. We've got Twitter, Facebook, Instagram, all at NHCOA. A recording of this webinar will be made available on our YouTube page. Any questions not addressed here, again, will be addressed in the comment section. Remember that it's everyone's job to work towards stopping the spread of COVID-19, and it is our duty to comply with public health guidelines such as wearing masks that cover your nose and mouth, practicing physical distancing, and washing your hands. Let's be agents of change. Let's do it for our family, friends, older adults, our communities, and the world we live in for ourselves. Additionally, I think as one of our first speakers mentioned, oftentimes we are the role models that our older adults look to. So if you have the opportunity to get vaccinated, please do so, because that provides the example for others in your community. Hope is essential in times like these, but let us remember that you are not alone, and together we will succeed. The heart of NHCOA goes out to each of you. Thank you, and until next time, goodbye.
Thank you, Christina. I'm Dr.
Thank you.
Thank you.